Speaker Madhava.
Gopi Srikanth sir, can you switch on your camera? Isha madam and Madhav also.
Venkat, background ఏంటి మంచిగా పెట్టు, ఎక్కడ పెట్టావు? మాకు కూడా వచ్చు కదా.
ఇది ఇల్లు ఇచ్చిందే కదా సార్, హాస్పిటల్ది కాదా?
అవునా, మాకు ఇవ్వలేదు ఇట్లాంటి ప్రివిలేజ్ పిల్లలకి ఇస్తారేమో అంతే, మాకు ఇట్లా.
Sir, we're good to start.
Good evening, friends. Welcome to this evening critical care meetings of Yashoda Group of Hospitals from the Department of Critical Care Medicine and other specialties. We welcome you to this evening session of today. We have seen a surge of dengue cases in the last few weeks, and also as a tertiary care center, we see complicated referred cases to us. And most of these referred cases were complicated, like with warning signs of polyserositis, severe thrombocytopenias, LFTs being dearranged. And most of these patients do well with a supportive care. But some of them who land up into a dengue shock syndrome with organ failures, they were little tricky. And we all understand that these patients, when they go land up into DIC, their mortality remains very high. And that was a common category which we have been knowing from decades together. But for the last few years, we have seen a new pattern of acute liver failure being not uncommon in these severe dengue patients. And we also saw some of the HLH in these groups with high ferritin, high triglycerides, leukopenia, which is persisting beyond those 7 to 10 days. So last month, we had a program where we presented a series of HLH cases with a dengue being the diagnosis, and these patients needing a treatment with HLH, and our hematologists were brought those cases. And for some reason, we have seen a couple of cases in the last week from dengue being the diagnosis, and that led to initial few days of thrombocytopenia, typical polyserositis, and multiple organ involvement. But later on, finally landing to acute liver failure. That is in the form of the transaminase being high, the synthetic function, INR keeps rising, lactates being high. They were in initial part of the encephalopathy. So these are the series where we actually intervened with the help of both our medical gastro and hepatology team and our transfusion medicine department by providing us the support. So we wanted to present these two cases in the last week in the series of our dengue by our senior consultant, Dr. Madhava Reddy, who has been a part of the critical care department in Yashoda Group of Hospital, Hitech City. He carries a rich experience of liver intensive care unit from Medanta also. He has been postgraduated from critical care medicine. So we have Dr. Isha, who will give us an overview of why we actually talk about Plex when we think about an acute liver failure, and how Plex as a machine or as a device is useful in these situations. Dr. Isha is our senior consultant in the transfusion medicine in the lab. Dr. Isha works for Yashoda Hospital, Hitech City. I welcome you, ma'am, on board, Dr. Isha, for the presentation. So with this, we have two eminent guest experts, Dr. Naveen Polavarapu, who is a hepatologist and also a transplant physician, carries a rich experience in India and abroad, and has his experience carries his experience from UK also. He has been a passionate person in this acute liver failure. I was fortunate to actually experience some of his early cases of acute liver failure with successful and gratifying recoveries. And this has been again another series. So we welcome Dr. Naveen sir to being on board, and it is a privilege and honor to have you on board, sir.
Thank you.
So we have one more dynamic and has been an academic person on board, Dr. Gopi Srikanth, who postgraduated from All India Institute, and he carries all his rich experiences of academic excellence, and he is being a part of our unit in Hitech City, Yashoda Hospital, and he will also being a part of one of the case. So we will take their opinion. So the flow will be something like that. Dr. Madhav will take us through the couple of cases for 10 minutes, and followed by Dr. Isa will take us through why Plex. And then we will take both of your opinion on the expert part, and also we will interact with our audience. And this will be probably a combination of the intensive care specialist and other general clinicians on board. So over to you, Dr. Madhav.
Thank you, sir. Thanks for the introduction. Okay. I'm going to discuss about the acute liver failure in dengue, severe dengue especially, and the role of therapeutic plasma exchange with the available literature evidences till today. Therapeutic plasma exchange is a procedure where we take the blood of the patient, and it passes through a medical device where we separate the plasma from other blood components. The method will be discussed by Dr. Isha sooner. The plasma is removed and replaced with a plasma replacement solution, and in majority of the cases, it is usually the plasma in case of ALF especially, and in other cases, it could be albumin, it could be other electrolyte solutions also. Dengue, the worldwide number of dengue cases are almost 400 million overall. The tropical the tropical countries are generally, it is quite endemic, and in other parts also it is now becoming a in view of rapidly increasing interconnectivity among the nations, with air travel becoming more frequent. So now it is becoming a worldwide problem, not only in tropical areas but also in temperate countries. So WHO classifies in 2009 dengue into 3 different categories rather than the earlier classification. Here, the dengue is classified as dengue without warning signs, dengue with warning signs, and severe dengue. Dengue with warning signs, usually the mild cases usually presents with a few days history of fever, rash, headache, and joint pains, myalgias, leukopenias, and clinically is diagnosed by positive tourniquet test when we don't have the rapidly diagnostic tools like IgM or NS1 rapid PCR test. Then the dengue with warning signs, where generally the patient requires a hospital admission rather than any OP-based care. Here, usually the presentation tends to be the upper abdominal, right hypochondriac pain with upper abdominal tenderness, persistent vomiting, gastric upset, mucosal bleeding, lethargy, restlessness leading to altered sensorium, and hepatomegaly, usually more than 2 centimeters in ultrasound, and increasing hematocrit trends. Especially these particular signs are showing there will be a capillary leakage, ongoing capillary leakage with a raise in the hematocrit, and patient is potentially at the verge of deterioration if appropriate care is not provided. Then we come to severe dengue, where the patient capillary leak further exacerbates the overall hemodynamic parameters, leading to hemoconcentration, lack of intravascular intravascular volume, leading to shock, respiratory distress because of the polyserositis, and inflammatory cascade that leading to ARDS kind of picture, with a very severe ARDS in some cases requiring mechanical ventilation, and severe bleeding tendencies including severe thrombocytopenia, lower GA bleed, upper GA bleed, and sometimes suddenly patients presents with altered sensorium, and then we find out directly in the CT that patient is having intracranial bleed. In our particular case of interest, the elevation of aspartate aminotransferases and alanine transferases greater than 1,000 units per liter, especially leading to, along with synthetic function derangement in the form of deranged INR, leading to coagulopathy and acute liver failure, and also hepatic encephalopathy. Dengue ALF is a culmination of multiple factors leading to failure of the liver in the form of direct cytopathic effect of the virus, also some amount of immune-mediated cell injury and drug-induced injury, and at the same time, because of lack of intravascular volume, leading to great amount of shock and leading to ischemia and hypoxia. overall multiple factors combining and leading to severe derangement in the liver function, causing acute liver failure. So the worldwide cases are around 400 million. The hospitalized cases tend to be only 100 million. Among these, less than 1% of the cases can progress to acute liver failure, where the mortality carries close to 50 to 80% without any appropriate management. Though we find these cases very frequently in our clinical practice, the published literature has a very scarce amount of reported cases, especially in adults. When I went through National Center for Biotechnology and Information, NCBI, through mesh wording of dengue plus thrombocytopenia and therapeutic plasma exchange and acute liver failure, I could hardly find 10 publications that includes individual case reports and cohort studies along both the adults and pediatrics. So that surprisingly very scarce literature is available regarding the therapeutic plasma exchange role in the dengue. This is one of the first published study among the adult cases with high volume plasma exchange. As high volume plasma exchange also is recommended as a grade 1 indication by American Society of Plasma Apheresis. Here the case underwent plasma exchange after initial presentation with the severe thrombocytopenia and elevation in the AST and ALT. Patient was admitted into the ICU. There is a gradual derangement in the liver function, including the deranged INR and hepatic encephalopathy. The patient underwent a high volume plasma exchange. They performed 3 high volume plasma exchange as recommended by American Society of Apheresis without waiting for the results to stabilize. So the continuous results can be clearly seen. Finally, the AST and ALT elevated into almost 3,000 into thousands, gradually settled down. The ALT from 3,920 to 2048, then 52, then gradually the patient recovered, and AST also from 19,000 to 190 after third plasma exchange. And then finally, the coagulopathy is also settled down and hepatopathy is also settled. Patient recovered from the hepatic encephalopathy and gradually discharged. Regarding the meta-analysis of case report published worldwide, our own colleagues from Delhi NCR have conducted meta-analysis of individual published case reports and other cohort studies, and they have identified the most common parameters among the ALF cases in dengue. And most common finding, one surprising thing is most of the patients are very young, whose the average age is around 38. So younger age groups have more predilection, and majority of the cases they have got are from the tropical countries. The diagnosis for the dengue ALF, the mean duration is close to 4.5 days. So as the severity of the disease is more with severe thrombocytopenia, the early presentation is usually associated with severe findings of early dengue association, is very close to association with acute liver failure. The biochemical characteristic and derangement of the organ dysfunction has other peculiar picture that includes most of the patients are leukopenic, and AST, ALT average elevations are into 4,000 to 3,000 ranges. AST by ALT ratio close to 2.45. The median INR is 2.13, and N-acetylcysteine being used as one of the most supportive care therapies along with MARS. And hepatic encephalopathy is also one of the most common finding among all these case series. Out of all these patients, around 2 patients underwent liver transplantation and successfully survived the episodes with very less reported deaths. So looking at these biochemical characteristics, we can identify we don't have to wait for the organ failures to proceed to a very severe derangement. Rather than early intervention probably could lead to better outcomes. There is another single center cohort trial published from the Vietnam. This is probably one of the largest published study for dengue with ALF, but this belongs to the pediatric, but this is one of the largest trial group published. So in this particular case, they have published a total number of 34 children where the median age is close to 10. And they have provided therapeutic plasma exchange along with CRRT, where the renal derangement, renal dysfunction is also one of the most common thing along with the dengue. So they compared that with standard medical management and showed that the survival rate is very, very, very good compared to the normal medical management. As you can see, the fatalities are also very, very low compared to the normal standard therapy or CRRT alone, not adding the therapeutic plasma exchange. The number of cases lead to fatality is very, very high. As you can see, 13 cases out of 87, whereas combined therapy, there are only 7 out of 37. The Kaplan-Meier curves also showing the survival probability with TPE, therapeutic plasma exchange, and CRRT is quite high compared to the regular standard medical management along with continuous renal replacement therapy. The same showed in terms of the parameters also. The parameters also showed greater amount of reduction with the combination of therapeutic plasma exchange rather than CRRT alone when combining CRRT with the therapeutic plasma exchange. With the initiation of the plasma exchange, AST, ALT settled down rapidly. INR corrected very rapidly along with a rapid drop in the ammonia level and resulting in significant survival rate and improvement in the hepatic encephalopathy grade. As you can see, the most of the patients from grade 4 before the plasma exchange, almost 10 out of 53 converted into 5 out of 26. So we have our own case series here to discuss regarding the number 1 case. The 33-year-old young male, no comorbidities, has presented on day 5 of illness, admitted already in an outside hospital with a gradual deterioration in the general condition, with epigastric pain, right, hypochondriac pain, worsening clinical condition, rapidly dropping platelets. And by the time he reached us, the liver enzymes were not elevated. The first recording of the first recording itself showed almost very much normal liver parameters on day 5. The patient presented with restlessness, but there is some amount of jaundice. The clinical assessment findings showed a left ventricular failure, preserved ejection fraction, where the patient went into kind of fluid overload, probably because of the earlier rigorous resuscitation, having right-sided pleural effusion, abdominal distension, right hypochondriac tenderness, peripheral edema, and altered mentation. We have managed initially with immediate, stopping further resuscitation and giving NAC diuretic infusion, as the liver enzymes only mildly elevated, was started with NAC infusion and very close hemodynamic monitoring, looking at the lactates. The initial lactates that we received were surprisingly high compared to his overall hemodynamic parameters. He was hemodynamically very much stable, no tachycardia. There was no hypotension, but still lactates went very high. Probably that says lactate probably is the earliest factor that could give a signal regarding the ongoing liver damage before even the elevation of the aspartate and alanine transferases. So we went ahead with the serial lactate measurements and close monitoring of liver parameters every 12th hourly, even before they started derangement. They started deranged. As you can see on day 5, the SGPT, SGOT levels are not significantly high, but we went ahead with every 12th hour monitoring of liver enzymes so that to identify the deterioration as early as possible. Within 24 hours, you can see the significant derangement of INR from 1.5 to 2.18, then to 3.32. So at this particular point on day 2, that is day 6 of total illness on the evening. So the platelets also fell to 9,000. We have given him 1 SDPC transfusion and went ahead with plasma exchange at this particular point. That led to a significant improvement in the SGOT, SGPT levels, and INR also got corrected artificially. Then the patient is supported with HFNC and very close hemodynamic monitoring. So the patient was never requiring any vasopressors. As you can see, we went ahead with the plasma exchange. The lactates have also come down significantly. With only 1 session of plasma exchange, the patient settled down very well, and we continuously followed the liver parameters for the next 12 hours interval, and the parameters more or less settled after that. Probably with early intervention, what we could see is we tied over the crisis, and that led to initiation of the recovery. And from that point onwards, patient improved drastically within 48 hours to 72 hours, then shifted out of the ICU. So the second case is a little bit tricky and more complicated. Here, a 56-year-old male with no comorbidities presented with, again, day 6 of illness, not very late into the course, very early into the course, with a significant amount of thrombocytopenia, shortness of breath, grade 3 to grade 4 with altered sensorium. With this particular patient has presented with in shock, requiring vasopressor support and abdominal pain. So the patient was having melena. We initiated SDPC transfusion. As the liver enzymes were deranged, we started with NAC infusion. Again, we followed the strict protocol of monitoring the liver parameters 12-hourly, serial lactate measurements with close hemodynamic monitoring. As you can see from presentation on day 6, the liver enzymes were, though they are on the higher side, not significantly bothering. The INR is 1.48. The next day by morning, you can see the significant jump in the SGPT, SGOT, almost they doubled. And by again, after 12 hours of interval, you can see again that got doubled. So see, that is why it is very important to have a closer look at the liver enzymes parameters, because if we watch for 24 to 48 hours of interval, probably we miss the window and probably the patient might deteriorate very rapidly. And here you can see the hepatic encephalopathy picture. The patient ammonia is also 95. We also sent for ferritin to rule out any HLS. The ferritin came high, but LDH and triglycerides are on the lower side. So HLS point is ruled out. And we initiated plasma exchange here on day 8, after morning. So with first session of plasma exchange, the liver parameters were settled significantly on day 8 evening. But as you can see, after 12 hours of follow-up, again on day 9, the liver parameters were significantly deranged. So at this point, we have decided to go ahead with the second session of the plasma exchange after consultation with our hepatology team. From that particular second session of plasma exchange, the parameters were very much settled. Patient encephalopathy got significantly improved, as you can see, from grade 2 encephalopathy to grade 1, and then within 24 hours into no hepatic encephalopathy grade. The platelets are also significantly improved, and the patient was off vasopressors, gradually improving, and finally, shifted to the ward. So one question is when to initiate the plasma exchange. There are no particular specific criteria defined when to initiate plasma exchange in dengue ALF. The clinical judgment and laboratory parameters trend is more important. Looking at the patient's INR values and consecutively synthetic ability of the representing synthetic ability of the liver, and serial lactate measurements, probably one of the most important thing, even before the liver enzymes are deranged, and sequential tracing of the liver enzymes with a close gap of almost 12 hours, that what we set for ourselves. And encephalopathy is another important parameter where we looking at it can proceed with therapeutic plasma exchange, and other organ dysfunction, especially the kidney and the LV dysfunction. Considering both of them, probably patient might be requiring CRRT along with therapeutic plasma exchange if needed in case of severity of the cases. But from our experience, early close follow-up and tracing of these laboratory parameters and early aggressive interventions can tide over the crisis and can save the patient from deteriorating further into a vicious cycle of multi-organ failure and requiring very high supports. Probably at that point, the mortality goes up very, very high. Thank you.
Thank you, Madhav, for that overview. We will now move on to the second part of the talk that will be dealt by Dr. Isha. Dr. Isha will take us through what exactly is this Plex and why we are talking about Plex when it comes to acute liver failure, and that too in the context of dengue. Over to you, Dr. Isha. So by the time Isha will come back with her sharing of presentation, Madhav, I think we have another case right now, a young girl with a myocarditis and even hypertension.
Yes, sir. Yeah.
But we don't see the same kind of 12,000, 20,000, 8,000 enzymes. Generally we thought ki ischemic hepatopathy or a congestive hepatopathy are not uncommon. But even though they are borderline with myocarditis, enzymes elevate up to 10 times, but not into the 10,000 or 20,000. In these cases, both these patients had normal pressures, but the enzymes were sky high. In fact, one of the cases initially we had a congestive issue. Isha ma'am, do you have any problem sharing the slides? Kindly share your slides, ma'am. Isha ma'am, can you hear us?
Or else, shall we share it, ma'am?
Yeah, please share it.
Okay.
Dr. Isha, we are sharing the slides for you. You can actually Dr. Isha, can you hear us? Dr. Isha, can you hear us? Ma'am, can you hear us? Dr. Isha, can you hear us?
Sir, I think so. There is an audio issue.
Is not able to hear. I think she must have been asked her to increase the volume. She can't even share the slide.
I think so, sir. The issue with the audio, I think so. Just wait. Mm.
Okay. So just speak to her and find out how we can
Okay,
fix.
okay, sir.
In the meanwhile, can we have both Dr. Naveen sir and Dr. Gopi Srikanth on board? Can we have?
Yep, we're there.
Yeah. Naveen sir, just to take this discussion forward by the time Dr. Isa gets prepared. See, I think when we actually reviewed the literature is very scarce. And the reason for that is probably dengue being a vector-borne and confined to the Southeast Asian countries and this part of the world. So there is very, very limited literature as far as the West is concerned. If they do a meta-analysis, they do on our patients or our data. So even though Dr. Madhav showed one meta-analysis, I have reviewed one more meta-analysis. It was done in US, but the patients are mostly from Vietnam, India, and then Sri Lanka, Singapore, and probably some of them from Thailand. So this is a disease to this part of the world with the vector being the problem. And we all understand the Plex or plasma exchange being a phenomenon which we have seen with different other etiological ALFs, including toxin-induced, where from maybe last decade we learned from CMC Vellore in the early parts that yellow phosphorus, in which they actually tried where there is no option of going for a liver transplant, they attempted to actually go through this Plex and they found a result. And now that has been extrapolated not just to only yellow phosphorus, but other toxins and other etiological agents, including the infective. Also, ACLF, now acute on chronic liver failure, also been an extra. But keeping that all aside, dengue being a special situation, where the same dengue just not causes the liver injury, that causes a multiple organ injuries. We see them causing septic shock, we see them causing AKI, and as rightly mentioned by Madhav, it is not just with other etiologies like hypotension or hypoxia, the viremia itself, because all our patients had never had any hypotension. One patient had some congestion. We initially thought it is a congestive, but later on when we treated that congestion by diuretics, his oxygenation got better, his other systems got better, but liver kept on. So it is a viremia induced probably pathological insult adding to the other things. So what do you think this virus plays? When we talk about hepatitis or acute liver failure, we talk about A, E, or some drug induced or some toxin induced. But these other viruses, including cytomegalovirus, herpes simplex virus, dengue virus, or a hantavirus, what is these other viruses' role in or being a cause for acute liver failure?
So you talk about the other causes of acute liver failure or in terms of the...
And that is now we are linking to even dengue.
Yeah. So yeah, thank you for having me for this interesting discussion. And also Madhav has actually nicely pointed about some of the data with regard to the Plex in particularly in dengue. So I think just for the audience sake, although we're going to discuss predominantly from dengue related, but I think something we need to talk about Plex. What exactly is this Plex? Probably Isha will discuss in a bit more detail about the Plex. What are different types of Plex? What is high volume? What is standard volume? What is low volume Plex? But essentially what Plex means is you remove the plasma, you exchange the plasma and you get a new plasma. Depending upon the volume, we call it as a high volume, low volume, and standard volume. The idea of doing a Plex is you remove all the the cytotoxins, the PAMs and the DAMs which get released in the SIRS response, whatever the etiology of the insult, whenever we have these PAMs and DAMs, that gets filtered out with this plasma exchange, and you get a newer plasma. We give an environment for the liver to recover, is what we see. And although we talking about a lot of Plex these days, but the evidence, as we discussed, is quite scarce at the moment, because there's not many randomized controlled trials which actually use the plasma exchange modalities. But there are certain studies which actually said that plasma exchange has been beneficial, particularly in group of patients like ALF, the ACLF patients, and also of various etiologies. And of course, there are also some studies which looked at etiology as well, which patients would actually benefit from the Plex in that etiology as well. For example, alcohol patients or hepatitis A patients, or even the paracetamol overdose patients. And as you already mentioned about the yellow phosphorus and the rodenticide poisoning, these are the patients where Plex really benefited compared to patients who actually had ALF because of Wilson's disease or autoimmune hepatitis. So there are such subset of etiological groups where Plex actually made a difference compared to the other group of patients. And
so it has used in a wide spectrum of indications of ALF, whatever may be the etiology, it has been used. So can we go back to Isha ma'am? Can you switch on your camera and can we have Isha ma'am slides, please?
Sir, I'm sharing, sir.
Yeah, please share this. Full screen, please. Yeah. Please go ahead, ma'am.
Good evening, everyone. I'm Dr. Isha. I'll be talking briefly about therapeutic plasma exchange in ALF. The next slide, please. Okay, so we have already seen the definition. Madhu sir has already spoken about this. TP denotes a selective removal of patient's plasma and replacing with another fluid, mostly colloids or crystalloids. The next slide. So what is the rationale for TPE in liver disease? In severe liver disease, there's accumulation of toxic metabolites such as bilirubin, ammonia, endotoxin compounds, and there's also clogging of acute inflammatory cytokines and DAMPs, and this can lead to sludging in the liver sinusoids. And this can lead to a sinusoidal obstruction, which further reduces the perfusion in liver microcirculation and causes hepatic failure. What TPE does is it helps in maintaining the cerebral perfusion pressure and in removing the toxic substances from the patient plasma. And when FFP is administered as a replacement fluid, it replenishes the coagulation factors and albumin and immunoglobulins. This will help in improvement of the microenvironment of the liver and help in the functional recovery of hepatocytes. Next slide. So what is the principle of plasma exchange that we are currently following? At our hospital, that is in Hitech City, and also all 4 units of Yashoda, we're currently using centrifugal plasma exchange on a newer model of spectroptia. Here, the blood components are separated based on molecular density by differential centrifugation technique. So this is what you can see. The circular image is the centrifugal channel. Here, anticoagulated whole blood enters the channel. The RBCs get separated out. You can see in the second picture, you can see there's a red layer, that is the RBC. And then you can see a thin layer, orange layer, that is a buffy coat, and the above layer is the plasma. So it gets separated out. There's a viewport on the machine, so you can see the separation happening live. You can see the whole blood being separated into RBC, buffy coat, and plasma. The plasma automatically gets discarded, whereas buffy coat and RBCs along with the replacement fluid goes back to the patient. Next slide. So there are different doses of plasma exchange in Plex to treat ALF. One is the high volume Plex, which refers to 10 liters of plasma exchanged per session of Plex. Standard volume is 2.5 to 5 liters of plasma exchanged per session of Plex. And low volume is 1.2 liters of plasma exchanged per session of Plex. Next slide, please. So here you can see the graph showing the fraction of intravascular substance remaining during plasma exchange. So there is something called exponential decay. So after one total plasma volume exchange, there is reduction of 65% of the initial value of the offending intravascular substance. And after 2 total plasma volume exchange, there is 85% reduction of the initial value of the offending intravascular substance. So you can see between 1 TPV and 2 TPV, there's only a reduction of 15%. So there is a diminishing effectiveness in the TPE procedure. So usually we do 1 to 1.5 times exchange of plasma. Next. So some biochemical changes, there is a decrease in platelet count between 30% to 50%. Again, this depends on the machine that we are using. Then there's a decrease in pathological antibodies, 60% to 75%. Coagulation factors decrease with the albumin, whereas in FFP, all the factors approximate to levels present in FFP. No significant electrolyte changes will be seen. Citrate is important because in FFP replacement, along with the anticoagulant being used, which is citrate, and FFP will also have citrate, this will reduce the ionized calcium level and further decrease the serum total calcium level. Next one. Okay, currently we're following ASFA guidelines, that is American Society for Apheresis guidelines. They have divided the disorders into 4 categories and they have given grade recommendations also. So category 1 is where apheresis is accepted as first line therapy, either as a primary standalone treatment or in conjunction with other modes. Grade 2 is a second line therapy. Grade 3 is where the role of apheresis therapy is not yet concretely established. So the decision making should be individualized on a case-to-case basis. Category 4 is where the evidence suggests Plex is harmful. Next one. So this is the grade system. Grade 1A is where there's strong recommendation and high quality evidence. This is because of RCTs without important limitations. Grade 1B, there's moderate quality evidence, but still strong recommendation. That is RCTs with important limitations. Grade 1C, there is low quality evidence. This is based on observational studies or case series. Next one. So high volume Plex in acute liver failure is given as category 1 indication with grade 1A recommendation as per ASFA, whereas standard volume Plex is given as category 3 indication and grade 2B recommendation. So according to ASFA, in ALF, daily TP is typically performed for a defined period as a bridge to LT or liver self-regeneration. The biochemical response to TPE should be evaluated with samples taken at least more than 12 hours post-procedure. This is to address the rebound or the recirculation from the interstitium. Next slide. These are a few RCTs that have been published. First, we'll look at RCTs published in ALF. So the first one is by Larson et al. This is a landmark open label RCT published in 2016. They have compared high volume Plex with standard medical treatment, SMT standard medical treatment in ALF cases, and they found that there is a 10.9% increase in survival rate in Plex patients compared to SMT. There's another open label RCT published by ILVS Delhi in 2022. They have studied standard volume Plex, not high volume. Standard volume Plex, that is around 1.2 TPV they have studied with SMT in ALF. Most common reason in this particular study, I think 40 cases were included in this study, and most common reason for ALF in this study was viral hepatitis. They have found that the 21-day transplant-free interval was 75% in Plex patients compared to 45% in SMT patients. Now coming to ACLF, there is one RCT which was published from China. This is ACLF related to hepatitis B. They have compared standard volume Plex with SMT, and they found that there is 60% chance of 90-day survival in Plex patients compared to 47% chance of 90-day survival in SMT patients. There's another study which is again published from China, open RCT, ACLF related to hepatitis B infection, where they have quoted that 51% 3-month survival is noted in standard volume Plex patients when the MELD score is 30 to 40 compared to 14% survival rate in SMT cases. If the MELD score is more than 40, then there is not much difference in the survival rate between Plex cases and the SMT cases. Next one. So these are a few studies which are published from India. These are all matched cohort studies. The first one is published from ILBS Delhi, where they have done comparison of high volume Plex with standard medical treatment in Wilson's disease causing ALF in children. This is a pediatric study. And they have concluded that the 90-day survival rate with Plex is 47% compared to 17% in SMT. There's another recent study published by CMC Vellore. This is yellow phosphorus or rodenticide poisoning in children. They have done low volume Plex compared to SMT, and there is a 30-day survival rate is 60% in Plex cases, whereas in SMT cases, the 30-day survival rate is 0%. Coming to ACLF, in alcohol-related ACLF cases, there's a recent study again published by CMC Vellore where they have noted that low volume Plex along with low dose steroid has improved the 1-year survival rate in patients by 38% compared to one year survival rate of 14% in SMT patients. There are again 2 more studies which again are alcohol related ACLF cases. They've compared standard volume Plex with SMT patients, and this is by AIIMS Delhi and PGH Chandigarh. Again, they have noted 3-month survival and 30-day survival is better in Plex standard volume Plex cases compared to SMT patients. Next. So this is the Vellore protocol. I have only highlighted the Plex part in this. So Vellore protocol states that centrifugal Plex is preferred. It should be done daily for 3 days. 50% of plasma volume is exchanged per session. Flow rate should be 25 to 40 ml per minute. 1:1 volume replaced with FFP, and calcium supplementation should be given during Plex to avoid citrate toxicity. The next slide. Okay, again, this is a study from Vellore. I included this study because this is, I think, one of the first studies comparing centrifugal Plex and membrane Plex along with standard medical treatment in very severe alcoholic hepatitis patients. They have studied total of 21 patients each in centrifugal Plex and membrane Plex groups, and they have concluded that there is better 1-year transplant-free survival in these patients treated with the centrifugal Plex and low-dose steroid compared to standard medical treatment. Also, there is better 1-year survival rate among patients treated with centrifugal Plex and low-dose steroid compared to membrane Plex with low-dose steroid. So they have finally concluded that centrifugal Plex may be preferred Plex technique to treat these patients. But since this is a retrospective study with a smaller sample size, large multi-center prospective RCTs are needed. Next one. This table is from the same study. So they have compared the biochemical parameters or technical parameters of centrifugal Plex and membrane Plex. So while there is improved survival of these patients in centrifugal Plex, they have postulated that there is slower flow rate during centrifugal Plex. This will cause lesser hemodynamic fluxes and steady vital organ perfusion. So the flow rate in centrifugal Plex is 35 ml per minute on an average, whereas in membrane technique, it is 125 ml per minute on an average. There is a higher plasma removal efficiency in centrifugal technique, and this decreases the volume of the plasma processed, exposure of blood to the external circuit, and complement activation. The fractionation of the blood components or separation is by molecular density in centrifugal technique, and it's by filter pore size and molecular size in membrane technique. So in contrast to centrifugal Plex, using filter to separate plasma may activate blood cells, worsen the systemic inflammatory response, and clogging of microcirculation in the liver and other vital organs. So the major differences are in plasma removal efficiency, the flow rate, and the flow rate. Next one. So this is again a table showing the differences we just discussed. Next one. So a few complications post plasma exchange. Of course, there are local complications, that is port-related infection, thrombophlebitis, bleeding. Very rarely arterial puncture can happen. And there are transfusion-related acute lung complications. Again, rare things, but to be kept in mind, especially during FFP transfusion, that is transfusion-related acute lung injury and transfusion-associated circulatory overload. Citrate toxicity. This is the most common side effect noted. One of the most common side effects noted post plasma exchange, citrate toxicity, because the blood in the apheresis system as such is anticoagulated, and this anticoagulant we are using is citrate. And again, we are doing FFP replacement. FFP also has a significant amount of citrate. So what this citrate does is it goes and binds with the ionized calcium and forms calcium citrate. This decreases the ionized calcium level, and it also decreases the serum calcium levels transiently. If in a patient with normal liver, This citrate is metabolized in 1.5 hours and patient will be absolutely normal. But TPE procedures will take longer, and these are patients with decompensated liver. So yes, calcium infusion during the procedure is a must to avoid citrate toxicity. Next one. Thank you.
Yeah, ma'am. Before we go to those questions, there were one question related to you. And the both plasma exchange and plasma paresis has been used exchangeably. So interchangeably. So just probably for the viewer's point of view, there were questions related to what is Plex, what is plasma paresis, what is plasma exchange. One question was there. Even that's a basic question. Can you explain that, ma'am?
Yes, so plasma exchange is what we are talking about currently. That is therapeutic plasma exchange. Yes, both of the terms are being used synonymously. They have slightly different meaning. Plasma pheresis we apply to donors, and therapeutic plasma exchange is for patients because we remove the plasma and replace the unhealthy plasma with healthy colloids or crystalloids. That is therapeutic plasma exchange. Whereas in plasma pheresis, there is something called single donor plasma pheresis. That is, it is not happening in India. Plasma is being collected from single donors. So it is related to the donor. But yeah, it is being used synonymously. It means the same thing. Removing the plasma and replacing with the fresh plasma.
Okay. We'll come back to you, ma'am, for the further questions. We'll take some questions to Dr. Srikanth Gopi to start with. Srikanth Gopi, sir, there were questions related to does therapeutic plasma exchange reduces ammonia levels too?
Yes, ammonia levels are produced because of the liver dysfunction in any etiology of liver dysfunction. So, plasma exchange and CRRT, these two are the mechanisms known to decrease the ammonia levels in critically ill patients. So, definitely plasma exchange does decrease ammonia. So, it has a role in it.
So was that also helps in maybe you prognosticating or you thinking that your patient's encephalopathy do improve and with correlate with the grade of encephalopathy? Is that any evidence to that?
Yeah, that's a good question. So, just to start with, first of all, to diagnose acute liver failure, apart from liver injury, a coagulopathy is a mandatory thing. So ammonia false elevation can happen due to other reasons also. So in a patient, so first we need to define ALF for a patient to have. So coagulopathy and liver injury are mandatory things. Without coagulopathy, if there is a hyperammonia, we need to look for other causes. Ammonia is a definite prognostic marker in acute liver failure. There is a score called ALFED score. It is ALF Early Dynamic Score, which has been proposed by AIMS New Delhi and used worldwide. In this score, ammonia is a very important prognostic marker in all liver issues, ALF, and consequently, it has been proven to have a very good prognostic marker in ACLF also.
So what are the components of that? What score was that, sir?
ALFED score is Early Dynamic Score. There we will look for
now, what are
ALFED score is AL. So components we have is INR, hepatic encephalopathy, ammonia levels are predominantly used in it. So with this, here it is called dynamic because we assess it at admission and again after 48 hours we see how is the trend within it. So it helps us to take a decision for transplant.
We'll go to the other question to our other expert, Dr. Naveen, sir. There were questions. You have a patient with acute liver failure, either with the dengue or any other etiologies. What is the time point at which you think about a therapeutic plasma exchange?
Now, that's a very difficult question to answer because, as Madhav already mentioned, there are no clear guidelines in terms of when you actually start the plasma exchange for these patients. But having said that, in terms of dengue, for example, dengue or any kind of acute insults, we look at not the transaminases, which is not the primary determining factor, which is the coagulopathy is what we look at. The patient is starting to have coagulopathy and encephalopathy particularly. So those are the patients where we think the plasma exchange would help these patients. So, or ascending lactic acidosis, lactates, as we say, lactates are very important predictors in terms of how the liver is responding. So high lactates, coagulopathy getting worse, and encephalopathy setting in. These are the patients where I think we should definitely think about plasma exchange.
So very precisely answered, sir. I think those. So how frequently you monitor them, and what probably will you recommend for those who actually managing these cases? And these cases are not uncommon, sir.
Yeah.
How frequently you want to
See,
manage?
I think for the peripheral places and the other centers, what I would suggest is if you see any patient with worsening coagulopathy, when I say worsening coagulopathy, the patient INR going more than 2 or beyond 1.5 to, or say definitely 2 and above, or lactates are going up, I think these patients should be managed in a center where there's an access to liver transplant as well. So they should be definitely referred to a tertiary center where they have access to the transplant. So that's the first point to note. And in terms of monitoring wise, I think lactates, ideally we should measure at least every 12 hours, if not every 6 hours. Coagulopathy at least every 12 hours. And of course, encephalopathy is a subjective phenomenon that we need to regularly monitor. And as Gopi said, ammonia only in the case of ALF and also in ACLF, not in CLD, not in chronic liver disease, but in ALF and ACLF, ammonia has got a good sensitive and a good positive predictive value. Certainly if they're above more than 92, and you need to also know how to actually collect this ammonia. It has to be collected in a proper way. Arterial ammonia is what we need to collect, and it has to be sent to the lab in a cold environment, in an ice pack. So that's how we need to send it. So only then we can say that this patient is probably would benefit from the plasma exchange. So I think plasma exchange should be initiated in patients who actually have worsening coagulopathy, worsening lactic acidosis, but in a center where we have access to the transplant as a fallback.
Yeah, you actually raised a controversy, Dr. Naveen. So if you go to the guidelines till recent times, we speak about acute liver failure, the standard of care. If you have a facility for liver transplant, you should opt. The things which started about in and around Plex are where the accessibility to the liver transplant is not there or the feasibility is not possible. So they try to actually bridge those patients into some form of other alternatives, including Plex. So if you look at the value, CMC value paper or ILBS, they initially it's not uncommon that every patient may not afford to a transplant. The liver may not be available to all these acute liver failure patients, and sometimes the feasibility is also not been possible. But the transplant being a standard of care for all acute liver failures. So now after the evidence or literature support of the Plex being actually, at least the evidence is growing day by day, what will be your take? See, you have a center where you have both availability of a liver transplant and you have availability of a Plex. And the other side is also true that even though you have a liver transplant facility, availability of the organ is always a challenge. And maybe sometimes a live donor from the family can be an option. So how do you take a call being a hepatologist in this?
Yeah, so I mean, again, this is a very difficult question to answer because the reason I say that is standard of treatment for the ALF patients has always been a liver transplant, especially if they fit the criteria for transplant, right?
Exactly.
Yeah. So, but the question about whether going for a transplant for the Plex as a bridging therapy to transplant, or is it as a standalone therapy? It is the answers are still out there. Jury is still out there. This question has not been answered yet. But I think what we do is, if the patient is fitting to the criteria for a transplant, but they are not willing for a transplant, so we have no other option other than trying. In other words, standard medical treatment versus the Plex, which Isha has already showed the evidence that especially ALF patients who are not having transplant, they have 10 to 15% improved survival rates in those patients. And the second thing is, if the Plex fails, then we go for the transplant as a fallback. So the point I was trying to say earlier is, yes, we can do Plex at a peripheral centers as well. But what we also need to understand that is, if that patient doesn't respond to the Plex. So when we talk about not respond to the Plex, is at least doing 1 or 2 sessions, particularly after second session. If they're not responding, then I think we should not wait and we should swiftly transfer this patient to a place where there's a fallback of a transplant, particularly if the patient is a candidate for transplant. See, logistics may get difficult once we know that this patient is getting sick despite doing Plex. then you may find it logistically difficult to get the patient across to a place where they transplant. Because if the patient is a candidate for transplant, as a hepatologist, we would like to know as early as possible so that we can keep the ball rolling. So we want to run the Plex and at the same time work up for the transplant parallelly. So that if it is fails, then we can go for the transplant pretty much straight away. Because time is essence there. Every minute counts there. We don't want to waste any of those time, any time at that time.
So very interesting points. Being you exposed to these transplants in an acute liver failure settings, Isha showed ki there is a 15%, 30%, yellow phosphorus, they have a 60% mortality benefit. But what is your experience with transplant? What is the survival rate? Is it 100% or they do well as like a cirrhotic patient or end stage liver disease patient, or how was their outcome in the transplant centers? So you have a transplant available.
Yeah, so if you talk about ALF related, when they fit the criteria for a transplant, and if we don't do a transplant for those patients, they have a near 100% mortality in patients who fit the criteria for transplant. I'm talking about those ones, okay? And if those patients, if you do a transplant, we talk about survival rates of almost 80%. This is the national, the standard international literature which says that 80% survival in patients who are actually fitting the criteria for the transplant. There's a criteria for it, criteria 1, 2, 3, 4, 5, 6. So if they fit any of those criteria, then we go with the transplant for those patients. So survival definitely improves with the transplant if they fit to the criteria for the transplant. Again, if you have paracetamol overdose and non-paracetamol overdose, there's also again difference to both of them. Okay, so paracetamol overdose patients, because they're present with hyperacute liver failure, some of them, even if you about 40 to 50% of patients, even though you don't do a transplant, they recover very well. In paracetamol overdose patients, but in non-paracetamol overdose patients, especially if they are non-A, non-B, non-favorable etiology, without doing a transplant, they have very poor outcome. So it also depends on the etiology as well for the ALF.
So taking it forward, Dr. Srikanth, Gopi, if you see Madhav's case series, in one case there was a high ferritin around 20,000, and when I was actually reviewing the literature, high ferritin or ferritinemia is not uncommon. Whenever a dengue patient comes with this serious illness with multi-organ failures, the ferritin goes high. Sometimes you also get associated with high triglycerides, high LDH, and other high inflammatory marker along with cytopenia fitting into the HLH criteria. And sometimes they are not. We have seen only isolated ferritin being high, and that is also been probably not uncommon in the literature, which once we reviewed. So how do you fit? One of his case has leukopenia in 2000, has also a high ferritin, but he said his other parameters, triglycerides and other, didn't fit. And when we actually calculated his even HLH score, the score was pretty low. We use HLH score, as you said, for your ALF scores. So what is your take on this overlap of HLH along with acute liver failure with dengue, and sometimes only hyperferritinemia with ALF?
So this dengue ALF is a very interesting phenomenon. If you see majority of the ALF, they are predominantly hepatotoxicity happens, and in some cases there will be immunity, hyperimmunity, like immunological reactions of the host, which is contributing to the hepatotoxicity. In dengue, especially if you see severe dengue or especially dengue hepatitis, severe dengue hepatitis happen in a patients who had a past history of dengue. It has to be second. It's more common happen in a patient with second episode of dengue. So here it is an immunity which is contributing more to the hepatotoxicity than the virus itself. Other ALFs, the immunological phenomenon, like they are like immunity would be suppressed rather than hyperimmune conditions. So the inflammatory markers I expect to be very high in dengue hepatitis compared to other kinds of ALFs. So apart from, if you see the IL-6 and TNFs, they will be very high in the first week of this dengue illness. And like in a COVID-like thing, it will be this hyperinflation will be contributing. So ferritin is an inflammatory marker and it will be elevated. The severity of this cytokines, like whether it is going to the storm and then landing into the HLF kind of thing, because macrophage activation is one of the pathophysiology in dengue. So if this macrophage activation goes beyond a point, then we will be getting into the HLS definition. But if it is not going into that spectrum of HLH, it will be a spectrum like mild inflammation to severe full-blown HLH. So there will be a spectrum, and ALF dengue-related ALF can occur in any of the spectrum. So what we have seen in this case, one of the cases, even we added steroids
Yeah.
in during this plasma exchange. So we should. I feel that my personal opinion is we should not just treat dengue ALF like any other ALF, because there's an additional component of excess inflammation in this, which can be seen by highly elevated ferritin and IL-6. So I feel that if we see high IL-6 or high ferritin and some HLH-like thing, or even without the definition of HLH, we should add some steroids and they may benefit.
So in the last discussion, or in the last session, we had this discussion related to the HLH, where we actually saw a good number of our patients who had a delayed cytopenia recovery, high-grade fevers after a couple of weeks of dengue fever. And also we have seen they being very highly inflamed. As you said, we are not routinely doing IL-6 and TNF-alpha, but ferritin has been not uncommonly practiced. So ferritin, triglycerides, and LDH and other markers are very commonly, including the CRPs, are done. As you said, during the COVID, these terms were very popular, like cytokine storm, and that leading to HLH. You said ki all these dengue patients will have some or the other form. Mainly the severe dengue will have an autoimmune also attack.
Yes.
As Madhav pointed out, the mechanisms are directly viremia induced liver injury, autoimmune induced liver injury, all that accumulates. So those who actually have some inclination with HLH, we considered adding a required dose of steroid, which helped in all these patients whenever is required.
Yes,
There
yes.
are some questions related also to Naveen sir. There is a question which is a very peculiar, like we use Plex and IVIG alternatively for GB syndrome and neurological condition. Here, is there any role of using IVIG if Plex is not available?
Good question. I think very interesting question. This is definitely should be for the research, I guess. But literature so far has not used any IVIG for these kind of for these kind of situations, conditions. To be honest, I think the idea behind using Plex for this is basically, as Isha already pointed out, the pathophysiology behind it is to remove the endotoxins and the DAMs and the PAMs to give the microenvironment of the liver to recover. So I think IVIG probably does not do that kind of a filtration techniques that we expect that with the Plex. So maybe that is a thing, but I have no experience with using IVIG in patients with ALF or with the ACLF.
Rightly pointed out. I think at this point of time, we don't have any evidence of using IVIG, which we use for antibody-mediated immune destruction, like some GBS and other kind of things. Another question, the repeated use of NAC has been presented by Madhav and has been also documented in the literature. So what will be your indication to use N-acetylcysteine in your ALF cases, either from dengue in other situations?
See, NAC, although it sounds very good that, it acts like an antioxidant, which should help in theory. And there are some studies, including RCTs as well, including one of these studies was published in the New England Journal as well, which showed particularly in patients with the severe alcoholic hepatitis, they had some benefit with NAC. But the benefit only lasted for about a month. The long-term survivals were not good for these patients. And also, it only improved in patients who actually had acute kidney injury along with the ALF. So patients who didn't have acute kidney injury in patients with severe alcoholic hepatitis, NAC didn't make any difference. It's only in patients who had AKI that actually made a difference. But theoretically, yes, NAC being an antioxidant, it seems to be beneficial, but it doesn't translate in the clinical medicine.
So just to add what sir has said, so alcoholic hepatitis, long-term mortality, there is no benefit. But as I think, there is a paper from Gastroenterology 2009 where they have shown that N-acetylcysteine has some role in non-paracetamol ALF also. So as a matter, and also some benefit, especially in non-paracetamol drug-induced hepatitis. So we regularly use N-acetylcysteine in all ALFs, and especially in early stages of ALFs, like hepatic encephalopathy grade 1, 2, but not an established hepatic encephalopathy grade 3 and 4. But the benefit will be only marginal benefit, because the side effects are only maximum of nausea, vomiting, and no other side effects. We can advise it.
So maybe that is
And there is
the
just
most common.
to add to yes, just to add to it, last point is there is a recent systematic review written by one of our colleague in Indian Journal of Gastroenterology. What they have shown that is in dengue ALF, the only drug which have shown to have some benefit is N-acetylcysteine
Okay. So
in the
as
systematic review.
Dr. Naveen sir pointed out, many of us use in view of it's not being very toxic, it's not very expensive. The side effects are limited to maybe not very lethal, but the evidence has its own limited thing. I think we confined ourselves of using NAC previous to 2009 was only paracetamol, to be very honest. Then later on, when other papers start turning up, even European standard guidelines talk about it can be considered in non-paracetamol toxins and other kind of things. I think we are just using them. But as the other side, yeah, sir, go ahead.
Yeah, so NAC, I mean, there are a lot of confounding factors when we use NAC. You know, as we all discuss, it's less harmful drug, that's why I use it. But actually, if you look at the evidence from using NAC by itself making a difference, it doesn't have any long-term benefits. It doesn't have any even short-term benefits as well, apart from some improvement in the blood parameters like renal parameters. But otherwise, it doesn't have any great benefit. And that's the reason why most of the guidelines don't even suggest using NAC as a replacement therapy for these patients. And we in ALF patients, I mean, at least our practice, and certainly in Birmingham, we never used to use NAC for non-paracetamol overdoses. Only for paracetamol overdoses, definitely we used to use it, but non-paracetamol doses is all subjective because there's no great evidence for it.
Yes, I think that's where individualization comes, but paracetamol, it's yes, definitely. Ma'am, some questions to you. There are questions related to, you said I can use as a replacement fluid as an FFP or albumin. So FFP can cause TRALI, albumin can cause coagulopathy. So how do you choose, how do you mix, and how do you play around both of them?
So there's definitely risk with FFP is, yes, risk of viral transmission is present because yeah, we're only testing for 5 viruses and we are not doing nucleic acid testing. So it can also cause TRALI and TACO, but FFP improves the coagulopathy. So if all of these ALF cases which come for plasma exchange, there's abnormal coagulation. So the preferred fluid of choice is FFP. Albumin we are using when there is, I think recently all of the gastro cases we have done 100% FFP replacement only. Albumin we are not using in cases of coagulopathy. And as per ASPA guidelines also, they have recommended FFP as the first choice of replacement.
Any comments, Dr. Madhav?
Sir, actually, we were doing so many plasma exchanges on a daily basis. We are consuming like 100 to 150 plasmas on a daily basis in Medanta. So then there was a crisis that we cannot provide any more plasma. So we tried to distribute them, and we were doing high volume plasma exchanges also. So we used to do initial part like 10 to 12 with FFPs, then proceed to albumin by 1 to 2 liters. Then we again end up having FFPs at the end of the session, probably to 1 to 2 liters, 3 liters of plasma as an exchange. So by the end of the therapy over a period of 8 to 10 hours, which happens slowly, we end up correcting the coagulopathy at the same time, where there is a serious requirement and unable to replenish the plasmas, and at the same time doing the plasma exchange effectively. That's what we have a jugaad kind of thing we made for ourselves.
But given a choice, you will prefer FFPs, plasma.
That's the first preference, sir. There is no doubt about it. But
so that's the answer, probably. Yes, sir. Anybody has any other comment?
So there is no head-to-head trial comparing albumin versus FFP. However, as we discussed, with FFP, you have corrective coagulopathy. With albumin, you have predominant effect of osmotic or increase in the oncotic pressures, along with some element of antioxidant benefit, but it doesn't actually correct the coagulopathy, and it doesn't actually help in clearing the toxins as the FFP, the plasma exchange, does it. So that's the reason why theoretically always FFP outscored compared to the albumin. And I don't there are any head-to-head trials on the albumin.
With this, I just wanted all four of you a question. When you do actually a plasma exchange, you remove the old plasma, replace with a fresh plasma. You replace your all your clogging factors. You replace plus plasma. So all your values will look much better after your plex. Is not it?
Yeah.
Your coagulopathy will get corrected. Your enzymes will look very like a synthetic function has improved. Your enzymes are dropping down. But at what point of time again you will relook whether your liver is really improved or not? Any lights on that?
Yeah,
See, you always pointed out don't give FFPs if you really wanted to see the liver function.
True.
See, in acute liver failure, if there is no plan for any intervention, if you are not really worried about any active bleeding, we don't correct the INRs because you don't just wanted to see the synthetic function, whether it is worsening or improving. In this time, when you do a plex, you actually replace. So it will correct your coagulation profile.
Yeah.
So how do you see that?
See, in acute liver failure patients, one of the important parameters that we actually see how the liver is doing is the INR, which we know, the coagulopathy, right? So when you correct the coagulopathy, you're robbing us away from an important parameter which will tell us how the liver is behaving. Okay, so that's the reason why we say unless they're actually having a significant life-threatening bleed, do not give any FFP. Even for patients who actually put a central line, if the INR is 8 or 10, don't bother about it. Just do a proper ultrasound guided access and then put a catheter.
I'm interested on this.
But
Yes.
yeah, but once you're committed yourself for doing plex, that means you are removing that kind of a parameter from the equation, right? So, but that also means that you have committed yourself that this patient is sick. This patient, we're giving FFP and then giving a trial of treatment. Okay, whether you call it as a bridging therapy or as the only treatment available if the patient particularly doesn't have a liver transplant option. Okay, so you cannot rely on the FFP once you start doing the plex. That is out of the question, at least for next 24 hours, whilst the patient is still having the FFP. The half-life is of course 24 hours. So subsequently, you will see that the the INR starts going up in patients who had a plex, right? So first 24 hours, we'll not even look at the INR. I'm not bothered about the INR. What I'm looking at that time is the lactates. I'm looking at the toxicity levels in these patients, not bothered about the INR. So subsequently, the reason I'm saying that plex has been beneficial, we all have seen in our cases. Certainly, we all have been involved in particularly alcohol-related ACLFs,
yes,
alcohol-related ALFs, and also in certain cases of hepatitis B that we've been using in our own center. There are significant benefit. Just to say, last Friday or Saturday, I was in Siliguri doing my outreach clinic. I saw a patient that we've been involved with a bilirubin of 44 when he came to us. He went to ILB to Delhi and other places. They said transplant was the only option. He came to us here saying that he wanted a transplant, but we wanted to try with the plasma exchange. And I was so happy to see the other day after doing the plexus and the treatment that we given, this bilirubin has come down to 4, and we came to my clinic walking. Patient with a bilirubin of 44, significant coagulopathy with significant amount of ascites, although we ruled out all the sepsis and stuff. Then we given the plex for him. We could bail him out of the transplant. Of course, we probably have not bailed him out permanently, but at least given a chance for him to stabilize, and he's actually doing well. So we have I'm sure you all have cases like this to discuss.
Very interesting points you made. You can't look at INR. You can't look at enzymes for initial 24 hours at least. Probably lactates is one option. The other is probably encephalopathy grade.
Yeah.
The other and other organ stability. Over to you, Dr. Srikanth. What do you think? We actually raised a concern that once you do plex, monitoring becomes a challenge, and the next day values may not be valid for you to say that the liver has started improving, is not it?
So the factors, coagulation factors produced by liver, the most sensitive factor is factor 7. Usually the maximum T-off of it is 6 hours. So after, like Isha also pointed out, that there will be volume redistribution after plex. So after 12 hours, if you could repeat INR and if it is still high, it suggests that there is definitely still liver dysfunction is going on. So you need not wait of 24 hours, but because the shortest half-life of the FFP which you have given may correct it for 6 hours. So only during procedure or give overnight, before night FFP and do the surgery next day morning. So you need to do during the procedure to get it done. So the half of life factor 7 is 6 hours, as I told you. So after 12 hours, whatever INR you do it can help us to assess. It is not completely false, but you need, like, at least it gives a assessment. And apart from that INR, we have other factors like encephalopathy, which can help in taking a decision. So, for example, in the same report,
lactates get cleared by your Plex because you are exchanging the plasma.
yeah. So, but the production of lactate, if the pathology is going on, will be
Yeah,
going.
even even Plex, if it clears lactate also, if the production
It
is
will be, yes.
it will come back in no time.
So, for example, in the two cases which we have done, we can see that after plasma exchange, the INR once it has come down after 12 hours, then again it didn't rise again if the INR is done after 12 hours.
So that's how you monitor. So the next question to Dr. Naveen. So there are questions related to the dose of Plex. So we spoke about the volume. We will come to Madhav for that. He has always been discussing about high volume, low volume, or regular standard volume. But to you, how many number of cycles of Plex and what is the decision factor? There are questions related to that. How do you decide 1 cycle, 2 cycles, 3 cycle? In many of our cases, including your case, we have been placing it one after the other and taking decisions. So how do you place it?
I think once you commit for a Plex, unless there are no contraindications or it hasn't developed any contraindications after the first Plex, I think we should do at least give it 2 Plex sessions. Then we see the response to it, is what we normally do. If they benefit from the second, we go with the third. Sometimes we even had cases, we've gone up to even 6 to 7 exchange of plasma exchange over a period of time. But that we will deal with based on individualized, based on the treatment response to each individual Plex sessions. But generally, I think we should do at least 2 sessions of plasma exchange before we say that the benefit of the patient.
Madhav,
it all depends on the, as probably Madhav will say, but it all depends on the volume. It's very important to choose the volume appropriately. So we don't want high volume for ACLF patients. They're already fluid overloaded. We want a low volume Plex for the patients with the ACLF. Similarly, for ALF, we want a high volume Plex so that we get a better benefit of the Plex.
Why I'm asking this question to Madhav is Madhav always get disturbed when this volume comes into action, and he kept on talking to me, sir, these are the volumes. So Madhav, over to you. What do you think about the high volume, standard volume, low volume Plex?
So there are two important things. One thing is regarding high volume plasma exchange. Doing it with centrifugal plasma exchange over a period of simple 2 to 3 hours, exchanging that kind of volume will put the patient at the risk of overload. That I agree with Naveen sir. But what we used to do in Vedanta was we used to use the TPE 2000 kit, which gives us a slower rate of elimination. So we used to prolong it for 10 to 12 hours. That will give enough time for the patient to adjust. And also we used to assess the patient in the middle, almost like 4 hours, 6 hours interval with ultrasound, and accordingly we used to adjust the replacement volume and keep the patient with plasma negative, where we used to avoid high volume plasma exchange without having fluid overload even in ACLF. But regarding the ALF patients, the Larsen trial, which is a very good randomized trial compared to standard therapy, showed mortality benefit with high volume plasma exchange. So currently for ALF, even American Society of Apheresis recommends high volume plasma exchange, 3 consecutive plasma exchanges. So with the available evidence, actually do not have any comparable high volume versus standard volume or low volume. But the supporting evidences towards high volume is good enough to continue that.
Isha, I wanted to raise a controversial question here. The guidelines were given here before, when this was the only trial which was talking about a randomized trial with a high volume. They gave it a grade 1A, but whereas they put it to the grade 3 to the standard volume or a low volume plasma exchange. But we have seen more and more evidences now coming up with more studies. What is your take on that? What do you do?
So Larsen et al. Published in 2016. There is definitive evidence that high volume works, but the most recent studies, CMC-Well or ILBS, they're all opting for standard volume or low volume in ALF cases.
Yeah.
So honestly, doing high volume plasma exchange, when I'm saying high volume, I'm saying 2 TPV or 2.5 TPV. It is a very long and cumbersome procedure. And like we were discussing before, FFP is a finite source. So if there is evidence that standard volume exchange on consecutive days is working in ALF cases, that is the way forward, maybe. This, I
What
think,
did you do in your two cases? What did you do in the two cases?
in dengue, sir.
Yeah, in the last two cases.
Dengue, we have done, we did high volume, sir, but dengue, the evidence in all the case reports, they have done either standard volume or high volume. They didn't opt for low volume in all the case reports published so far.
Okay.
And
We
we
did
had
1.5 TPV, sir.
we had
Dr.
a
Srikanth, Gopi, you
ALF.
want
We
Yeah,
had
we'll come back to you.
a drug-induced ALF also we successfully treated, which was almost we considered for liver transplant also, but we successfully treated that case with 3 consecutive high-volume plasma exchanges. Surprisingly, the patient came out of it.
Dr.
Sir,
Srikanth, you
can I?
wanted to have a comment?
Yes, sir. We like with the latest evidence, standard volume is as good as high volume, and standard volume plasma exchange with complete FFP without albumin is as good as high volume. And coming to this is regarding ALF. There is no data of low volume plasma exchange in ALF. Coming to ACLF, the CMC has come up with a very good data showing that low volume plasma exchange is good enough along with steroids if in alcoholic hepatitis. Otherwise, in so our like because with the current data, we are happy with low volume plasma exchange in ACL.
Dr. Naveen, there is a very interesting controversy which he raised is steroids in alcoholic hepatitis, which is probably a standard of care according to your scoring system. If they fit, you use steroids. But in the cases of ALF with the dengue and HLH, so we have seen the studies where compared low dose steroid plus Plex in acute liver failure, Dr. Naveen. We are also talking about HLH with ALF in cases of dengue. If you use steroid, what will be your dose of steroids in acute liver failure with HLH? Like what you do for a alcoholic hepatitis?
See, for the alcoholic hepatitis, I mean, first disclaimer for all these things is we need to make sure, especially for alcoholic hepatitis, is we need to make sure this patient doesn't have any sepsis on board. That's the most important thing. I think that's definite contraindication for both the Plex and for the steroids. So the evidence in terms of giving the steroids for alcoholic hepatitis is always been a high dose steroids. We talk about almost 60 milligrams of steroids for these patients, very high dose. And I'm sure most of you are aware of the trial called STOPA trial, which was a landmark trial which compared pentoxifylline versus steroids versus standard medical therapy versus combination of pentoxifylline and the steroids. In that, there was no huge difference in terms of the I mean, pentoxifylline hasn't outscored compared to steroids, but the standard treatment has been the steroids, and the steroids have shown benefit compared to the other standard other therapies. So we give a high dose steroids for patients who actually have an alcoholic hepatitis. But as you rightly pointed, patients with ALF and
HLH.
in alcoholic hepatitis patients and because sorry.
ALF with alcohol, sorry, HLH in dengue.
HLH. Yeah, I think the evidence for that is very minimal, and I think we generally use low dose steroids for these patients. Even if it's a HLH with ALF, we use a low. But again, there are few and far between patients with ALF with HLH. They have very poor prognosis to start with. These patients with the HLH.
Isha ma'am, Dr. Naveen has pointed out if you have a patient who has a suspected bacterial infection or some sepsis, so we are worried about when we actually opt for a Plex, because this patient can be thrown into immunosuppression with all those possibilities. So what is your take on that?
For active sepsis in particularly ALF cases, yes, Plex is a contraindication. But again, sepsis with multi-organ failure, to correct the sepsis coagulopathy, Plex as per ASPA has moved to category 2 indication. But in ALF, if there is active sepsis, I think there is that golden period where there is silent inflammation. We have to choose the right time to do Plex. Once there's active sepsis, no point opting for Plex in ALF cases, sir.
There is another question to you on your comment, membrane versus centrifugal. So the question talks about if I don't have a centrifugal machine to do a plex, can I opt for a membrane? You showed a study comparing all the three in combinations. So what is your take?
Sir, if plasma exchange is indicated and there is no centrifugal machine in that particular hospital, so it is better to do the plasma exchange even with the dialysis machine. But if you have two platforms to do dialysis machines, and there is evidence coming out that centrifugal method is better than membranous, it's always better to opt for centrifugal. We can't say no, I won't do plasma exchange just because machine is not there. So you have to do it on
Dr.
dialysis machine.
Madhav, I have a patient with acute kidney injury needing a dialysis and I need a plex. What will I opt for? I will do a CRRT along with a centrifugal exchange, or I will opt the same in the same machine. What do you do?
Sir, actually, if the centrifugal machine is available, it can do it in 2 hours. So considering the entire down timing of a CRRT, 18 to 20 hours is more than effective CRRT for 24 hours. During that 4 hours, if you can remain effective during the 20 hours of CRRT, you can use that 4 hours downtime for a plasma exchange session, then followed by CRRT, keeping it standby. That is one way of doing it. Otherwise, there is other possibility. You can put another HT catheter if you are running with membranous plasma exchange. You can run two machines at the same time. One is doing CRRT, another one is doing the plasma exchange if it has to extend for 8 to 10 hours with membrane filtration technique. But membrane filtration technique, obviously, if the centrifugal is not available, it's always better option. But the centrifugal has a lower citrate dosing that is required actually, because it completes earlier. So the blood flow is on the lower side. The citrate anticoagulation is dependent upon the amount of the blood flow into the number of hours. So the entire citrate load on the patient and citrate related adverse effect and toxicity is considerably lower compared to the membrane filtrations.
The citrate has been always considered to be enemy to this acute liver failure patients, and that has been always questioned when regional anticoagulation has been used in these cases. So, Dr. Srikanth Gopi sir, will you wanted to answer the citrate in acute liver failure, the use of citrate as a regional anticoagulation?
So, definitely, as already Isha has shown that we didn't find any specific problem using citrate in liver failure. For example, we always used to do plasma exchange by centrifugation, and the data regarding the centrifugation versus membrane, there is a little diversity from the Western data and Indian data. For example, the CMC have shown that centrifugation is better, but the Western data have shown that centrifugation is as good as membranous. So there is this controversy. So it's again like because of in our settings, which is done in our settings, so centrifugation might be better.
So there is another question which you can answer. What are the other poisons? I think some question is, can it be used in organophosphorus? The answer is no. We don't use plasma exchange for organophosphorus poisoning. There is no indication and no use there. Acute phosphorus poisoning role, you actually were aware of those data. So what is your take on that?
Yeah, in acute phosphorus poisoning, definitely, as you already said, the CMC has a very good data of plasma exchange, like ALF due to this phosphorus poisoning.
So we can use that as an indication.
Yeah.
Any grading was given by your American society there for phosphorus poisoning? Maybe in the future.
Yes, so based on all of these cohort studies, I think in the future, maybe next edition.
Okay, we'll take the final comments. We had a very successful, I think a panel of so much of knowledge and wisdom. So it's always a learning experience. So we'll take the final comments from all of you to wind the session. So any final take from you, ma'am?
No, sir. I think, but I want to reiterate and say actual high volume plasma exchange, which is 2.5 TPV. I feel that graph where at 1 TPV, 65% of the unwanted intravascular substance is removed, and 2 TPV, only 85% is removed. So even if we progress to 3 TPV, the entire unwanted substance is not removed. That graph is never going to zero. So I think sticking to standard volume, that is between 1.5 to 2, is the ideal volume. This is from my end.
Any take home from Srikanth sir?
So regarding this dengue ALF, just identify the risk factors like any coagulopathy at presentation, high lactate or low pH, and I would definitely give N-acetylcysteine. And regarding the doses, one is important. I often see rating 1.2 gram BD, but please, I do prefer, like, if you are treating for hepatitis and severe hepatitis, give it in a ALF protocol as infusion. That is important thing, not as 1.2 gram BD. And consider Plex based on the coagulopathy, encephalopathy, and ammonia levels.
Okay, any comments from Madhav?
Sir, as we have already discussed regarding our own case series, the very close monitoring of the patient in terms of his, sensorium encephalopathy and sequential lactate monitoring and liver enzymes 12th hourly. All those things provided us a good picture when to intervene, and all the interventions, and though they are very limited, they gave us a good idea about why we need to rigorous monitoring of these patients, at least as close as 12 hours at least. Because once we skip the 12 hours, then the 24 hours window will come. Probably by that time patient might worsen and land up with a proper ALF. Once the ALF sets into grade 2, 3, you have to intubate the patient. You cannot leave him into grade 2, 3 encephalopathy and wait for the recovery to happen. And once he go on to mechanical ventilation, probably we lose a lot of our golden period. So I think very close monitoring and aggressive intervention, early call for plasma exchange without hesitation might leads to good recovery, sir.
So final and concluding comments from Dr. Naveen.
Yeah. So first of all, it was a very good interactive session. Thank you for having all of us, and I think we learned from each other definitely. I think adding, I think all the points have been rightly pointed out, summarized very nicely by all of us, all other speakers. The only thing which I wanted to add is acute liver failure, or liver failure for that matter. It is racing against the time, so I think it's very important that we pick up these patients at a very early stage, and so that the right intervention can be done at the right time. And any doubt, I think they should talk to the tertiary centers in that matter, in that aspect. In fact, I wanted to invite you all as well for the GAPS program, the 2.0 that we're doing. And exactly the similar cases will be discussed in the GAPS 2.0, which is on this September 29, which is Sunday. And one of the topics is going to be on acute liver failure, racing against the time. And of course, there are other topics like acute GI bleeds and the acute abdomens that will be discussed. So I think I would urge all the emergency physicians, intensive care doctors, and the physicians, whoever sees these kind of acute GI patients, I think it would be a very interesting session. So I would invite you all for this GAPS 2.0 program on September 29th at the Yashoda Hitech Hospital auditorium.
Thank you. We will also convey and resend that flyer which you have sent to us, sir. And thank you for all of your time and sharing all your experiences and knowledge. Thank you, Srikanth, Gopi sir. Thank you, Isha ma'am. Thank you, Madhav, for that presentation. And thank you, Naveen sir, for giving us time in the video schedule. It was a privileged, honored discussion from all of you. Thank you. I conclude the session.
Thank you, sir.
Thank you.